a month if this is your first time, and it's an unusual conference where I share cases and share you digitized slides, show you the morphology with the history, and then give you an opportunity to give me a differential working diagnosis and or potential investigations. We've changed platform now with Diagnexia. They've changed to this new webinar platform, so it's a little different, so bear with me because I've got to get used to this as well. As in the past though, you can put your comments or your questions on the chat, and I'll pick it up from there and comment on it. Just as a reminder, Ava has put in the future meetings for next year, the first 6 months, and that's in the chat. And if you sign up for that, you'll get a reminder as well. Now, I recall we left, the last meeting we had in November, which is where we left with this case. And this was a 36-year-old male with lymphadenopathy in the head and neck. And this was a neck lymph node. And I shared this case with you right at the end, leaving you to think about it. Just to remind you, you can see the lymphoid tissue capsulated and entirely replaced literally by these granulomas. I just have to take this. Sarah?
Hi, Dr. Cooper.
Can you check with Dr. Jalal? Is it a head and neck?
I can. Yes.
Please.
Let me call him.
I'm on a conference. I'm on a conference. Yes. Thank you. Okay, sorry about that. It was frozen sections calling. So you can see the granulomas, well-formed granulomas, epithelioid granulomas. And the question I left you with, again, I've got to find these cells in between, which were large and monocytoid, or I shouldn't use that word monocytoid, but mononucleated, and had large nuclei, vesicular chromatin, and prominent nucleoli. So I'm just going to try and find those for you. Whilst I'm looking for those, is there anybody who was on the last time had any thoughts on what we are looking at? So it's granulomatous lymphadenopathy with these large cells in between. Now to see your answers, I've got to switch screens. So let me show you these cells before I switch screens to share with you these large cells with prominent nucleoli. These are difficult to find today. Let me see if anybody's put in some answers. No, nobody's coming up yet. Okay. There's some of these here, but those may be immunoblasts. Let's see if we can find any large cells. I should have dotted them. Okay. The last meeting I did find a whole group of them that I was able to share with you. I don't seem to be having much success today. Those may be endothelial cells. Some of them did look like that with prominent nucleoli. Oh, there's one here. Here's one here. So they were scattered about, but you can see these large cells, and another here. Distinct nuclear membrane and distinct cytoplasmic borders. Chromatin a little stippled, and with a discernible prominent nucleolus in a background of granulomas. Anybody have any thoughts? And in lymph nodes as well. let's see, what is the initial thought? There's yes, Sheena, Hodgkin's can show up with granulomas. That's absolutely correct. Tom, initial thoughts with sarcoid like drug reaction, and Hodgkin's with sarcoidal granulomas. Vinod, sarcoid versus Hodgkin's, and Shamila, Hodgkin's. Thank you for all of that. Yeah, that really is the consideration. This case was shown to me by my colleague and friend, Dr. Adam Bag, who's also formerly from South Africa, and he'd received it in consultation. These cells do not mark up with the Hodgkin's panel. So you all know the Hodgkin's panel, and when I used to do lymph nodes, Hodgkin's panel to me used to be a CD15 and CD30, but I know nowadays they do have a wider panel. And he was happy that these were not Hodgkin's cells, and you're absolutely right that Hodgkin's can present with this background of granulomatous inflammation. And here's another of those cells. So let me see if there's anybody contributed anything more. Hodgkin's sarcoid. Okay, so the answer really is these are follicular dendritic cells, and this would fit with the inflammatory variant of a follicular dendritic cell. And to really get a full understanding of that is best to look back at the literature. And when you look back to the original inflammatory FDC, follicular dendritic cell sarcoma paper, the inflammatory variant. I'm not talking about the traditional variant or the variant that occurs in Castleman disease, unicentric Castleman's. I'm talking about the inflammatory variant. It wasn't called inflammatory variant. It used to be called an inflammatory-like, pseudotumor-like, that was described in the liver in the early 2000s. And those used to be EBV positive, and these are EBV positive as well. So that's the way you make that diagnosis. And then subsequently around 2010, again, John Chen described lymph nodes with granulomas, like we're seeing here, as well as lymph nodes with eosinophils. So those are two separate, or may have been the same paper. If you Google John Chen with that inflammatory variant of FDC, you'll get those papers. Then more recently, these have been described in the GI tract, again with a similar morphology and presenting as polyps. Here you can see these large cells here now, prominent nucleoli, and we seem to be finding them now much more easily. They've also been described in the upper aerodigestive tract, with a few cases being described in the oropharynx and hypopharynx as well. So it's something to think about. They're very rare, very unusual, and I've seen now probably about 3 cases. I saw one in the GI tract that was shown to me by a colleague from CHOP. He was a hematopathologist, and that was also proven inflammatory FDC, follicular dendritic cell sarcoma. So these are very rare, but they now recognized as a definite, distinct entity. And this is the first one I saw in a background of granulomas, and I just share that with you. Let's see if there's any comments. Wonder if granulomas are frequent in EBV. Yeah, well, that's what I think it is. That's what I think it's an EBV associated follicular dendritic cell sarcoma. And that paper I referred to, there's one by John Chan. It's in the American Journal of FRCPath, and you can easily find that and Google that variant. And there's another with eosinophils as well. So both those one has to keep in mind. It was a more recent paper, I think, from China, giving different morphological variants of the inflammatory FDC in the liver. They go into hemangioma-like and inflammatory-like, and it's worth just looking at those because it gives you an idea, as to what you're looking at when you see these. They're very rare, but it's good to pick it up if you find it. Any questions or comments on this? It's a tough case. It's not easy. Yeah, Sheena, you'd want to demonstrate, the FTC markers and EBV concurrently in these cells, and the FTC markers are currently CD21, CD23, and CD35. Those are the ones we use. And there are some others described in the literature. I'm not sure if we have this as well. And we use EBA for the RNA. Epstein-Barr virus RNA, that's the one is most sensitive and specific. But it can be difficult to get FTC markers demonstrating immunoreactivity in these. And I remember when John Chan presented this in the 2000s at a conference in Australia, and he presented the inflammatory pseudo tumor variant EBV associated FTC. That's what it was called then. And I asked him a question, and I remember this clearly asking him how best, which is what you've just asked, how best can we highlight these cells and distinguish them from the background. And he said EBV was the best marker to highlight them and light them up. So if you don't have EBA, it's a useful marker to have EBA-ish in situ hybridization. So it's nice to have that. The others are not very sensitive or specific. It's the EBNA DNA. That's the protein, and there's also the DNA in situ. They're not very specific or sensitive, but the EBA works very well. Certainly in our hands, we use that. And the other tumors, I'm not going to go into them, where EBV or EBA-ish is very useful, most notably nasopharyngeal carcinoma. Okay, let's see if there are any other questions there. Yeah, okay. All right. There aren't any more. What we'll do is we'll move on to the next case. This is also staying in the head and neck. So let's see what you think of this. Okay, this is a superior nasal cavity mass in a male. It's an adult male, superior nasal cavity mass. And we see 3 sections here, so I'll just pick the center one probably and just share with you clearly these neoplastic islands, this tumor here. You can see these nodular configuration separated by this fibrovascular band of collagen tissue. I'll just go down on this just to show you these on a higher power. Okay, sort of small to medium-sized cells. Some of them are vacuolated. I think that's more artifact. We can see that there as well. It's probably artifact. Here are some strands and cords. There is discernible cytoplasm, but the cytoplasmic borders are not that discrete. But you can see some cords and nests and sort of trabecula, and then these larger islands, round cells. Some of them have nucleoli. Okay, and you can see the chromatin there as well. Okay, so again, just to remind you, sinonasal cavity on the superior aspect of it. Any thoughts? Let me see what you write on the comment. That's the only way I can communicate with you. Nothing so far. Any suggestions? Any immunohistochemistry that you would like to see? Let's see the rest of it. Again, just same sort of pattern, pretty much repeated what we saw and said earlier. There are these smaller nests and cells. Aha, so we're getting some hits. That's good. Okay, so I'm getting neuroendocrine carcinoma. I'm getting a request for neuroendocrine markers. We've talked about this in the past. I typically like to do all 3 markers, synaptophysin, chromogranin and INSM1. And so neuroendocrine carcinoma, yes, that would be a good differential. Before we come back to that, let's address NKX 2.2 for ALS. ALS is adamantinomatous like Ewing sarcoma. And those typically are CD99 positive, which is useful, but they're also diffusely keratin positive. So that would be an important consideration as well. The best way to rule out ALS is to do a FISH for EWSR1, and they are keratin positive as well. Tom has put in an acronym that we created a while back, which is a way to go through the small cells, undifferentiated small cells in the sinonasal tract, and to work that out. I can come back to that. Sheena, I and I want thinking of the SMARC proteins. That's good. And there's another request here for keratins, P40, desmond, synaptophysin. So let me, and those are all appropriate. Those are all appropriate. In fact, there's also a nut carcinoma as well. And so those would be all appropriate, working up these small blue cells. What I did not share with you is this is a young male. He's 21 years old. And the tumor cells are diffusely neuroendocrine positive, and both synaptophysin and chromogranin are positive. But equally so, A1A3, which was requested here, was also positive. So CD99 was negative, and SMARC B1 and A4 were both intact. So diffusely neuroendocrine. So when I think neuroendocrine, I see Heber has mentioned neuroendocrine carcinoma, I always ask myself, is this neuroendocrine carcinoma? Is it olfactory neuroblastoma? Or is it olfactory carcinoma? And yeah, Tom has put in olfactory carcinoma as a differential there as well. And the distinguishing feature in olfactory neuroblastoma and olfactory carcinoma is the fact that olfactory carcinoma is diffusely keratin positive. This is described about maybe 4 or 5 years ago, and I think there was a paper by Bishop in the late teens, 2018 or so, maybe earlier thereabout. If you go Justin Bishop olfactory carcinoma, that paper will come up where they described a small cohort and recognize it. I think the new WHO does recognize olfactory carcinoma, largely because of the diffuse keratin immunoreactivity. This has also been supported by molecular studies showing, I think there were some preliminary studies showing ARID1A alterations in these tumors. So it seems that it is different and distinct from the other neuroendocrine tumors. But that's my approach, where I have to do those stains in order to help me understand or distinguish olfactory carcinoma from the other 2 neuroendocrine tumors. There's a couple other things. Oh, so S100 can show the sustentacular cells. Yes, they can. And then, of course, nut carcinoma, you'd have to do the nut antibody to recognize that. The acronym that Tom put into the chat was, I've changed that, Tom. So what I've made it into is MR is Mr. And I put in HINDESLEEP. So that's what I typically use now. And M is, so these are for undifferentiated tumors in the sinonasal tract, and M's for melanoma, R for rhabdomyosarcoma. H is for HPV-associated sinonasal carcinoma, which can be small and round, and I is IDH-associated carcinomas. N is nut, so that's nut is included in there. And the D stands for DECF, which is a recently described, again, about 4 or 5 years ago. DEK, that's the first gene, and AFF is the second gene, DECF-associated carcinomas, which have also, I think, Dr. Lewis, Jim Lewis first described that. That's also an AJSP. You can find that. S is for several. It's small cell carcinoma, squamous cell carcinoma, SMARC deficient carcinoma. So all those S's fall in there. L is for lymphoma. E is for esthesioneuroblastoma. But remember that Ewing's or Ailes also comes into that differential as well. And P is pituitary, because you can occasionally get pituitary tumors in the upper superior sinonasal tract. So that's an acronym which I copied from Lester Thompson, who you know from California. MR Sleep, Mr. Sleep. I had added the HINDE because the more recently described entities like H for HPV associated, IDH, NNUT, D, DECF. E is for EGFR associated carcinomas as well, which typically, as you know, may arise from the inverted papillomas which carry that mutation. Okay, so there was just a little side acronym for you. Okay, if there aren't any more questions or comments, I'll move on to the next slide. Nope, I cannot do it there. I've got to go back to this screen. And oh, we're staying in the sinonasal 46015. 46. There we go. So we're staying in the sinonasal space. This is a sinonasal mass. And this is also a young patient. This patient is 21. Now, this is not the best of, in fact, more recently, earlier this year, I had a better case. But this is normal sinonasal mucosa. You can appreciate the serous and mucinous glands here. Some of them are dilated and on forming beautiful lobules. So it's probably a good start just to show you these, just to remind you what the normal sinonasal glandular components are. But the lobular configuration is important. And this was a case that was diagnosed outside. In fact, it was diagnosed at Johns Hopkins. And the final surgery was done here. So I was able to get a little bit of this tumor, and I scanned it just to share with you, because we don't often see these. And here you can see these glands here, which are pretty crowded. And I'm going to go on high power just to show you the atypical architecture, sort of back to back, some of these, and very uniform appearing here, much more crowded here as well. Bit of a comparison, that's also very crowded back to back, and here as well. This is a tough case, but just curious what people think. And like I said, it was, biopsied earlier, so this was just the remnants that I had. I saw another one, I think around July, August, that we had, which is much better. I must try and get the slide from that and scan it. Any comments as to what this is? A young patient with these crowded glands in the sinonasal. Any thoughts? Go back to the just to show you the normal glands. You can see the serous and mucinous components here as well. And these, as you can see, are just uniformly crowded back to back, very bland looking. And I can see the reluctance to give an opinion. I can understand that. Low grade yes, correct. That's exactly what it is. And remember, when we think about the adenocarcinomas sinonasal tract, I think the first thing you want to do is rule out the salivary gland type carcinomas, right? Like mucoepidermoid, adenoid, cystic, etc. So after ruling those out, you're then left with these seromucinous glands in the sinonasal tract, and they come in two grades, as you know. And we know this put it very nicely: low grade and non-intestinal, because the intestinal ones are typically high grade, and they behave very aggressively. And intestinal means that they do have intestinal differentiation. So CDX2 and CK20 are positive. The only way really to distinguish it from a colon carcinoma is by clinical and radiological correlation. So if this is the first time presentation, you'll always have to indicate in your comment that has to be ruled out, metastatic colon carcinoma. And then the low grade, which is this, that comes in sort of two flavors, two morphologies. One is these glandular components like you're seeing here, very small, uniform looking gland, very crowded, back to back, and does have this A-tip here as well. The one I saw in I think it was August, maybe in August, was much better than this one here as well. These are the ones that have here. You can see almost sort of papillary-like structures here. I should have shown you this. This is also very very abnormal compared to normal-looking glands, and that's all I had. It was just around there. The rest of it looked normal. So it was residual, low-grade, non-intestinal sinonasal adenocarcinoma. I think, and you can check me out on this, but I think the low-grade ones have been the ones associated with woodworker's disease and dusts. You all know that from medical school, right? And that's what for board exams as well. Yeah, carpenters. Thank you, Sheena. That's where the woodwork and dust comes from. So, so when you're next looking at your sinonasal mucosa, and if you see crowded glands like this, just be on the lookout for this entity. But it has to be preceded by radiological mass forming. Like I said, this is just the residual part of it. With a mass on radiology to help you identify it better as well. Yeah, just there's some interesting entities, and I may have another slide of another entity that I shouldn't talk about it. When we come to it, we can mention it. Also has atypical glands, and we can talk about that when I get to that. Any questions or comments in the chat? Okay, so we got the diagnosis and we got the etiology there very nicely. Thank you, guys. Let's look at this here. 4550. Oh, I'm doing it again. Yeah, this new system has me a little confused because I need to go back and forth between screens. This is my digitized slide screen, which you can all see, and I can control it and show you the slide. But when I go to the platform screen, here you can still see the screen, but I don't have control over this. I cannot enlarge it or make it small, so that's why I'm getting used to this. So bear with me. This is a 63-year-old woman, and this is a right groin mass, 5 centimeters, 5.1 centimeters. Okay, right groin mass, and here low power. It's a nice thing about scan slides. You can look at beautiful low power. You can see it's fairly decently circumscribed, but when you look at the periphery here, you can see clearly invasion here into fat as well. You can see these large islands of cells. I'm going down on high power just to give you a closer look. You can all spot the vacuoles that are coming up. You're all asking yourself, what are these vacuoles? And whilst you're doing that, I will show you some of the tumor cells as well. And you can see these large pink cells, medium-sized nuclei. Some are large, some are prominent nucleoli. Most of them have nucleoli, actually. And you can see a very nicely distinct cytoplasmic border. And you can see these vacuoles here as well. Okay, so again, some of them are nested, and some of them are cords and single cells. Okay, and you can see this in infiltration here. Look at these cords. And the stroma. Okay, you can see the stroma here as well. Seem to be more evident between these islands. Here, there's not much stroma in between. These are more sort of solid tumors. Here you got some multi-vacuolated cells as well. And again, note these nuclei Some of them are quite pleomorphic, ugly looking. Some are just round, prominent nucleolus. Let's see what thoughts are. What are the thoughts so far? Okay. We're getting onto the vascular uh, uh, differentiation, and EHE meaning epithelioid hemangioendothelioma. And a nice example of that, you can see these epithelioid cells, large nuclei, prominent nucleoli, and then I didn't want to use this feature as a not to give too much away, but you can see some of these are vacuoles and single cells, and those are the earliest endothelial differentiation in these single cells, univacuolated. Remember that vacuoles don't always mean fat. They can be vessels as well, and I've seen vacuoles in melanomas, and of course, the signature cell carcinoma, which is probably the most important cause of vacuoles. And then I've seen melanoma, and I've also seen signature cell lymphoma. So be careful of that. But these are large, abundant cytoplasm, very pink cytoplasm with these beautiful vacuoles, and here you can see the stroma, the myxoid stroma, embedded in that myxoid stroma, which is very useful for that diagnosis of EHE. Here you can see necrosis as well, which brings me, before you ask, yes, we did prove that Campter, I didn't see a blister cell. Yeah, Sheena, isn't the blister cell the univacuolated cell, where you have just one nucleus with the vacuole? I don't use that term, but I've heard people presenting. Yeah, here's a single vacuolated cell. It's similar to a signature cell for all intent and purposes. Here's another one here as well, but not sure why people use the word blister. But yeah, I've heard it being called blister in national and international meetings. I guess I don't like that term. That's why I don't use that term. To me, a blister is in the skin, not this. These look univacuolated. And all right, so yes, I think those are what they call blister cells. So these are all vascular markers, ERG, CD31, and then of course remember you do have other 5 when I last checked types of hemangioendotheliomas, and this is unique because of its unique fusion genes, CAMTA1 and WWTR. So yeah, Sheena agrees with me that these are blister cells. Thank you, Sheena. So those are so this is just a classic EHE. Now I was honing down to this area where there was necrosis, and what it was doing with that was just reminding myself, because there is a paper in AJSP, and I think it's either Japanese or Chinese. I cannot remember, but maybe the Japanese group. You can check it out, AJSP, where they give criteria for stratification, risk stratification, because that there's this controversy, EHE intermediate grade and EHE malignant. So this does have necrosis, so I assume this would go into the malignant category, malignant EHE. There's a higher risk of recurrence and metastasis. But that paper does give you all the criteria. You can look at it. I'm not sure whether the WHO has adopted those criteria. Nice, beautiful cords and nests, classic. And remember, these were first described in the lung, right? This goes back like 40, 50 years ago, and they were called IVBAT, intravascular bronchiolar alveolar tumors. They didn't have vascular markers in those days. And then when the vascular marker CD34 came out, which is the first one, which nowadays we hardly ever regard as a vascular marker, then those were recognized typically around the bronchiolar alveolar cords nest, invading the alveolar space with this accompanying myxoid matrix. And then, of course, there was the liver description, which can be multifocal, also in young patients. And then of course, soft tissue and bone became evident, and we recognized them. So this would be one in the soft tissue. Nice example of an EHE. Any other comments? Let's see if there's any other comments. Okay, no other comments. You have your blister cell, Sheena. So Yeah, risk stratification. I talked about that. Let's move on to another case if there's no other comments or discussion points. 105 right there. Okay, yes, this is another interesting case. I saw a couple of years ago. This is from 2023, actually. I saw this with Faizan Malik, who's now attending at St. Jude's in Tennessee. So this, you can see this. Oh, I should give you some history, shouldn't I? I'm going on about Faizan because I like him so much. This is a 1.6 centimeter chest wall mass. Okay, and you can see this, and the age of the patient is 70-year-old male, and this is it. This was excised. This came in as a consultation, and so there's a multi-nodular, multi-lobular configuration, just to point that out to you. I think people generally use those terms interchangeably, I think. But, lobule for me comes from the epithelial tumors, thyroid and breast, etc., etc. And then that's where I prefer multi-lobated or multi-lobular. So this, even though it doesn't all look uniform. I know some people also use the term multi-nodular, like, myxofibrosarcomas and exoskeletal myxoid chondrosarcomas. They say multi-nodular, multi-lobular. So I think it's interchangeable. Anyway, the tumor you can see is quite bloody. That is skeletal muscle, just to point out. And then this is fat as well. If you go and look at this fat, some of it looks a little funny, but we won't worry about that for now. So this is a chest wall mass. Let's go and look at one of these lobules, and it's just full of blood. And I want to try and show you the cells. Here you can see these cells, very pink cytoplasm, spindling here, but in between you can see some that are more epithelioid as well. So they seem to be admixed or intermixed, epithelioid cells and spindle cells, and forming these cords, and then of course these nests, but just stuffed with blood, no mitoses, and the sort of varying size and shape. You can take and do what you want with that, but there's a more epithelioid looking cell, and then, like I said, interspersed with these more spindle cells. Okay, let's see so chest wall mass, 70-year-old, angiosarcoma, yep, because it's blood filled. HHV8, Nariman, you meaning KS, Kaposi sarcoma? Is that what you're thinking? Could it be Kaposi's? Yeah, that has to be considered as well in the differential. I think in Africa is the only place I'd make a diagnosis of Kaposi's without any HHV8 stains. Look here, there's some hemosiderin as well. Remember, in Kaposi's you like to have some hemosiderin. You also want some plasma cells as well. This does not have any plasma cells, but it does have hemosiderin pigment. It is multinodular. Yes, KS is multinodular as well. So I guess if you want to do the HHV8, cannot be faulted for that. Let's see what the other thoughts are they were building up there. Got Tom, spindle cell hemangioma, Jan, spindle cell hemangioma. So what about the epithelioid cells? I'm just challenging the guys who say spindle cell hemangioma. What about the epithelioid cells? How are you going to explain those away? So let me go back to spindle cell hemangioma. Remember, those were first described by Enzinger and Wise, I think, as spindle cell hemangioendotheliomas, as those blue blebs in the extremities in young patients. And they had these large gaping channels, some of them having phlebothrombosis. And then the spindle cells were these wispy spindle cells around these large vascular channels. So this is just filled with spindle cells as well, but it doesn't have the. And then what happened to that spindle cell hemangioendothelioma was they realized that they were just benign, because earlier on they thought that they recurred with satellite lesions, satellite nodules in there. they discovered that it was just one tumor, and I think around early 2000s it got downgraded to spindle cell hemangioma. So that's the background for spindle cell hemangioma. And then there's this entity of epithelioid hemangioma, which are plump cords, even forming vasoformative areas, soft tissue, bone, multinodular, very pink, large nuclei, prominent nucleoli, pink cytoplasm, no mitoses, and easily discernible, again, forming vascular channels as well. And that, correct me if I'm wrong, carries the FRCPath alterations as well. And this, with the mixture of spindle cells and epithelioid, was described by Dr. Fletcher in early 23. And the reason I remember that is because this case is from 23. I've got a 2023 number on it. And that paper we saw was literally months earlier, and then we saw this case. So it's nice to see something published and then you find one within the next month or two. That's happened to me a few times. So this is it's a mixed spindle and epithelioid hemangioma. A subset of these do carry the FRCPath, and if you go back to the paper with Dr. Fletcher, you'll find that a subset of these do show FRCPath, but not all of them. And I guess with that differential we're getting, one would consider that as well. Michael has suggested anastomosing hemangioma. Those are first described, as you know, in renal sinus fat, and they also sort of infiltrate, can have some extramedullary hemopoiesis, and they can even form these hobnailings and form distinct channels as well, small capillary-sized channels. But they've been described outside of the renal sinus fat, in the pelvis and other GU areas, as well as soft tissue, and they carry the GNAQ mutation, GNAQ mutation. So that's it's a good thought, benign. So anastomosing is a good thought as well. So that's what we call the spindle and epithelioid. Look at the pictures. In fact, when you look at the low power, there's one picture that looks identical to this, with this multinodular configuration, very well circumscribed. Remember, the anastomosing hemangiomas are more infiltrative. Okay, this is very well circumscribed as well. Okay, great. Let's see anything else. Oh, Tom has put up a reference. Thanks, Tom. Like that, you guys can find that as well. There are no other comments. Let's see, we can throw in a couple more cases here. So epithelioid and spindle cell hemangioma, and it's 2023 Fletcher. That's the paper I think Tom's just put up. Now, moving on. Let's see, another OR 236. Okay, this is another interesting case. Love to hear what you guys think. We're probably going to sit with this now for the next few minutes just to hear what you guys think. This was a breast mass, and the breast people like to give a clock designation. It was 3 o'clock and a 2 centimeter from the nipple at 3 o'clock. Patient is 63, female, 2 centimeter mass, and this was a core biopsy that we received from the outside. One of our sister hospitals about 100 miles west of us, and I'm going to show you what this core showed. There's some fat here. That's pretty much it. So it was, we didn't know where it was. There's no normal breast tissue here, so it's hard to know where we are. We did subsequently get the resection of this, and I scanned that as well, and I have it as a slide in one of my subsequent slides. But here, just to show you, nice spindle cells, storiform pattern. Okay, there's some vessels as well. I'll go down and show you the different areas, and here you can see it involving fat as well. All right, this sort of infiltrative into the fat. But let's start with the spindle areas, and just to show you what these look like. It's sort of literally nondescript cells, aren't they? Very pink cytoplasm, spindle, no mitoses, very uniform looking, and pink cytoplasm. Okay, And I just would say before you give a differential, wait until I show you these other areas here where the cells look a little more plump. All right, a little more plump, and you can see from the nuclei that those spindle cells are probably the same as these, which have become more spindled, sort of irregular looking nuclei, some binucleation, some even multinucleation. So sort of more spindled, ovoid, twisted looking nuclei, irregular membranes, and a pink cytoplasm. Let me see if I can find you more other looking interesting areas. No, that's going too far out. Yeah, there's more of these twisted looking nuclei, and that's multinucleated as well. That's multinucleated as well. Sort of little bubbly looking cytoplasm in some of these cells as well, spindled as well. So let's see what the team is thinking. Okay, yeah, Tom loves this case. Heba, metaplastic carcinoma, absolutely. Yeah, so you're going to throw all your keratins at this. What's the patient's age? 60. Oh, beg your pardon. Patient's age is 63, correct, 63. So you're going to throw all your keratins here in order to rule out metaplastic carcinoma. I know the breast people like P63 for that, so they swear by that, and they love P63, and with the triple negative breast carcinomas, they also use SOX10. So you may throw all your keratins at this tumor because of the spindle cell nature. Sheena's given absolutely fibromatosis, and I would also want to rule out carcinoma, metaplastic carcinoma, and I also want to rule out fibromatosis, both of which, as you know, are differentials in breast pathology. Fibromatosis, usually actin positive as well, and the fascicles are usually much longer and sweeping. These are much shorter, in fact, forming some storiform looking like areas. And for fibromatosis, yeah, I'd like an actin and a beta-catenin because they carry the mutations, as you know. Rule out metaplastic. DFSP, correct. DFSP CD34 is useful for that, Jan. And then, of course, yes, Naeem, and the nodular fasciitis, I've seen that in the breast as well. Those can occur, and we typically like to do the USP6 rearrangement, particularly in the breast, because of the differential diagnosis that has been mentioned by other members of the team. Metaplastic carcinoma, it's nice to have a USP6, particularly in the breast. And if it is nodular fasciitis, you can watch it because they usually can shrink away. But surgeons don't do that. They go back and cut it out, I know. So far we're getting, and DFSP, yeah, CD34 positive, and if you don't believe your CD34 and want to do PDGFB rearrangement, you're welcome to. We do have the fish for that as well. I hardly ever do that. I usually go the clinical, an exophytic polypoid mass with the storiform, tight storiform. But I know the myoid areas can look like this in DFSP. Remember, you can get about four or five different types of morphologies in DFSP. The myoid variant can look like this, and so can this fibrosarcomatous variant. But there's no mitoses here. There is a tip here because the nuclei look twisted and irregular, like we saw on the high power. I'll go back and just give you another look as we're thinking about this case, and we did all of that, by the way. It took us about 2 days of immunohistochemistry, and all of those came back negative. Beta-catenin and all the keratins were performed, and the outside people also did some markers as well. So we added to that and expanded our profile. Here again, just that looks a little more multinucleated. I think ignore the vacuoles for now. They're more artifactual. These would be the more plump plump looking cells here, large and abundant cytoplasm. Okay, and then getting to these spindled areas, you can see these much more storiform-like areas, and that's where the DFSP comes from, because of the storiform appearance. So those are all very good morphological different. I like that myofibroblastoma. Yeah, they tend to be smaller, stubby nuclei as well, ovoid looking, and then I always like to do stains to confirm that, Sheena, and I would embark on Desmond CD34 and RB1 as well, retinoblastoma gene 1, which is important in that differential diagram. And ER is also useful in that respect. So yeah, we covered that as well. We covered myofibroblastoma, the muscle markers in CD34 net Desmond negative, and I think RB1 was intact. So we really did about 30 different stains on this. Oh dear, it's frozen sections again. Hi Sarah, can you hear me? No, she cannot. So any other thoughts? Any other thoughts before? Let's see. Sorry, I got myofibroblastoma. Yeah, these are IgG4. Sorry, I missed that. IgG4. Are there enough plasma cells to consider that? I know people generally see a lot of plasma cells and love doing IgG4, but the storiform fibrosis, yes, that would be a component. You also want the thickening of vessels, phlebothrombosis, thickening of the vessels as well to help you with that. But no plasma cells. So I think IgG4 is a diagnosis that far too often entertained very quickly. I like to have both the mass IgG4 serum levels, and then also all three features: storiform fibrosis, the vascular changes, as well as a high IgG4 plasma cell population. So always look for that triad. Okay, so on day 3, we then started to think outside the box, and what was interesting was that Faizan mentioned we should throw in a histiocyte marker. At the same time, I said yes, we should do an ALK, and both of us just looked at each other and said, whoa, could this be an ALK associated histiocytosis? And lo and behold, yeah, the markers came back positive, and we did prove that. Now Tom, I'm going to ask you to put he's already onto it, and they do have some peculiar genes which I can never remember the partner with ALK. So that's also Rosai Dorfman can look very similar. S100 will be useful in that context as well. Cyclin D1 too. So this is an example of an ALK-associated histiocytosis, and we've seen, I think, 2 cases of that. This was one, then the dissection, and I think I saw another one as well. So be on the lookout for that. These were first described again by John Chen in the early 2000s in children, liver, spleen, and then they expanded to multifocal disease, including the brain, and then they expanded to young adults and then older adults as well. And one of the sites, apart from liver, spleen, lymph nodes, is also the breast. And there's a small series, I think from China or maybe Japan. I think it's Japan. A small series of breast ALK-associated histiocytosis. It's a nice paper because they show the same spindle cells. One of the pictures, it's histopathology. No, I think it's AJSP. It's AJSP, and I think that may be the text that Tom is. Yeah, that's the one that Tom's put in there. So, any comments, or if not, we just have 2 minutes. I just wanted to point out to you that the next meeting is January 14, same time. That's Eastern Standard Time, 1 p.m. my time. And then I've given you another 5. So there's in the chat, if you go back to the chat, right on top, Ava Carr has put out the different, the schedule for the next 6 months. So keep that, and let Ava know if you are not getting the invitations, and tell your friends and join us. And if I don't see you, enjoy the holiday break and have a great, peaceful new year. So with that, I can take any questions if there are any questions. I'm looking down at the chat. Future dates, yeah, Ava's put that in again. Can we preview? You know, Nariman, that's something that I've been working with Diagnexia, and we're still working on a way to and they've scanned my slides. I've given them a couple of sets, and the idea was part of that to put out 5-6 cases that you could preview. But the problem, it's technical one in getting the slides from the storage where these slides are, to be able to put them out or to give you a link, because clearly they don't want to give you a link to the entire lot, and that's what they've been working on. You've reminded me now. So what I'm going to do is I'm going to ask my good friend and the chief medical director, Professor Ranjan Shetty, to look into that again, whether his techies have improved on that. So I don't know what that is. NGTONSILDX. Okay. Thank you. Yes, thank you guys. Thank you for the comments.